Type C malleolar fracture. A type C malleolar fracture occurs when the foot is in pronation and an extended rotation force is applied to the ankle joint. The first injury to occur is a deltoid ligament rupture or a medial malleolar avulsion fracture. The talus rotates externally. It forces the fibula to twist about its vertical axis. The result is a rupture of the anterior syndesmotic ligament and then the interosseous ligament up to the level of the oblique fibula fracture. A fracture of the Volkmann's triangle is caused by the shearing movement of the talus. With the planned anterolateral approach, the intermediate dorsal cutaneous nerve must be taken into consideration. The internal fixation is performed with a 7-hole 1/3 tubular plate with a lag screw through the plate. It also involves lag screw fixation of the medial malleolus and a screw fixation of the Volkmann's triangle from the ventral direction. A positioning screw secures the syndesmotic ligaments. The fracture is reduced and the plate is applied. Contouring is not necessary. 4 screws are placed in the distal fragment and 3 in the proximal fragment. Through the third proximal plate hole close to the fracture, a neutral hole is drilled with the 2.5 millimeter drill bit. The length of the screw is measured. The hole is tapped with the 3.5 millimeter tap and the appropriate sleeve. The 3.5 millimeter Cortex screw is inserted. A final fracture reduction is done over the plate using a toothed reduction forceps. The third distal plate hole is drilled eccentrically. After tapping, the screw is inserted, resulting in axial compression. The gliding hole for the lag screw is drilled through the plate and in the near cortex only, with the 3.5 millimeter drill bit and appropriate drill sleeve. Using the 2.5 millimeter drill and guide, a hole is drilled through the opposite cortex. The length is measured. The opposite cortex is tapped with the 3.5 millimeter tap, and the 3.5 millimeter lag screw is inserted. The reduction forceps is removed. All remaining plate holes are filled except the second distal hole, which will be used later for the positioning screw. On the medial side, the dorsomedial approach is chosen. The tibio-posterior neurovascular bundle must be respected. The approach is through a dorsally curved incision behind the medial malleolus. The great saphenous vein and the saphenous nerve are encountered in the ventral section of the incision. The medial malleolus is reduced. Preliminary fixation is done with a 1.6 or 2 millimeter K-wire. The 2.5 millimeter drill bit is used to drill for the 4 millimeter cancellous bone screw, parallel to the set K-wire. The length is measured. The 4 millimeter cancellous tap with appropriate sleeve is used to create the threads. The 4 millimeter cancellous screw with short thread and washer is inserted to achieve interfragmentary compression. The K-wire is removed. Drilling is done with the 2.5 millimeter drill bit. The second 4 millimeter cancellous lag screw is inserted in the same manner as the first one. Next is the screw fixation of the Volkmann's triangle from the front. As an alternative to cancellous screws, fully threaded Cortex screws with a lag screw function could be used. The Volkmann's triangle is reduced and is preliminarily fixed with the large, pointed reduction forceps. An oblique 2.5 millimeter anterior-posterior hole is drilled from the ventral direction for the 4 millimeter cancellous lag screw. The length is measured. The 4 millimeter cancellous tap with the appropriate sleeve is used to cut the thread. It is important that the thread of the 4 millimeter cancellous screw takes hold only in the Volkmann's triangle. The 4 millimeter cancellous lag screw with washer is inserted. The compression effect is clearly visible at the fracture line. If necessary, a second 4 millimeter cancellous lag screw is placed to protect the fragment from rotation. The reduction forceps is removed. The internal fixation is completed with the positioning screw. The fibula is temporarily fixed to the tibia in the notch with a 1.6 millimeter K wire distal to the plate. In the clinical situation, the foot needs to be extended dorsally for the insertion, as the fork at the upper ankle joint is at its widest in this position. The positioning screw must be inserted at a 30-degree angle from the dorsal direction and parallel to the tibial plafond. This screw should be inserted 2.5 to 4 centimeters above the anterior syndesmosis. The 3 cortices are now drilled with the 2.5 millimeter drill bit and the appropriate drill sleeve. The length is measured. A screw of about 36 millimeters will generally be long enough. The 3 cortices are tapped with the 3.5 millimeter tap and sleeve. A 3.5 millimeter Cortex screw is inserted as a positioning screw. The temporary K-wire is removed. Here are the positioning screw parallel to the joint, the Volkmann's triangle with screws inserted from the front, and the lag screw fixation at the medial malleolus. Alternative techniques. With a small Volkmann's triangle, the AP lag screw will not exert interfragmentary compression. In this situation, a 3.5 millimeter Cortex screw with over-drilling of a gliding hole up to the fracture gap may be used, or the screw fixation can take place from the dorsal direction. This is the fixed fragment with the 4 millimeter cancellous lag screw and washer applied from the back. As a variation, the medial malleolus can also be fixed by tension band wiring. On the cranial side, the wire can be guided over a 4 millimeter cancellous screw with washer, rather than through a transosseous drill canal. And that concludes this variation of the internal fixation.